Good morning. It's Wednesday, February the 23rd. I'm Chief Medical Officer here, Dr. Steve Stites. Thanks for joining us on Open Mics with Dr. Stites. We are streaming live on YouTube, Facebook, and now on Twitter. Today, there's more than just food in your stomach. There's trillions of bacteria, fungi, viruses, and other single-celled organisms residing in your gut. And a new study finds it's those things that will determine how severe your case of COVID will be. Dr. Florence Aslinia from the gastroenterology department here at the health system and the leader of the first and only multidisciplinary inflammatory or irritable bowel disease, IBD, and actually I didn't even say that right. I'll let you explain it, but IBD patient care program in Kansas joins us to talk about that in just a moment. And I should be able to talk about this because I'm one of your patients, and so this is going to be a great conversation. But before we get to today's guests and COVID numbers, Jessica Lovell joins us now from Studio B with a look at the day's top medical headlines. Good morning, Jess.
Hey, Dr. Stites, good morning to you. A severe COVID-19 infection not only can lead to breathing problems and high fevers, as we know, but what we also know is some patients experience diarrhea, nausea, vomiting, which suggests the involvement of the gastrointestinal tract, something you just mentioned. Researchers at King's College in London in the UK found that the system in the gut where microorganisms live was severely disrupted in severe COVID-19 cases. And this was regardless of whether there was evidence of virus present in the gut or not. The Prairie Village City Council has voted to end its indoor face mask mandate. And this change will take effect Tuesday, March 1st. Also, Mission's mask mandate will expire at midnight tonight. Masks, however, will still be required in all public spaces in Roland Park. That will be through March 16th. The CDC is working on plans to give you a break from wearing your face mask all the time. Officials say with infections, hospitalizations, and deaths on the decline. So now there's no timetable that has been set for this, but the CDC says it will soon put guidance in place that encourages prevention measures that will protect the public health and our hospitals. In non-COVID related news this morning, a new study just out finds that gun deaths have overtaken car crashes as the leading cause of death by trauma. This is according to the study published in the journal Trauma, Surgery, and Acute Care, that more than 1.4 million lives were lost to guns in 2017. That is compared to 1.37 million from car crashes. We take a live look now outside into downtown Kansas City, where if you are heading out, be aware of the wind chill. It is pushing minus 20 degrees in some areas, so please bundle up. This cold snap may be foreshadowing some more snow coming tomorrow. So make sure you get your questions sent in to us on YouTube, Facebook, and the Medical News Network. You can find links to those right there on your screen. Dr. Stites, I'm going to send it back to you now in the studio.
Thank you, Jess. And, just to say, with the CDC thinking about loosening their guidelines, we'll probably talk about that a little bit more. Hawkeye will be here in just a moment. But also the news breaking this morning, some suggestions that we're going to end the mask mandates on air travel and in airports, perhaps around March 18th. What will happen is that the current restrictions will just expire. If that happens, we're really going to be testing and seeing how well we're doing with disease transmission and what a difference natural immunity and vaccine-induced immunity are going to make. Because once we let people travel and we crowd airplanes, we crowd airports, we crowd public spaces, we'll see just how good we are. And I think that's going to happen someday. And it sounds like March is going to be a big month here in the United States. Let's see if there are any reporter questions on the line today. All right. We're going to turn to our guest, Dr. Florence Aslinia, who joins me this morning. Please, go ahead. All right.
Hi, was that for me? Did mine come through or not?
Yes. No, well, I didn't hear you, so go ahead and ask your question.
Okay. Hey, Dr. Stites, if you can hear me, just wanted to see about advice for parents as far as encouraging their kids to wear masks if they so choose when masks mandates are now gone for a lot of schools. They may be headed back to school this week for the first time. I know that's the situation for my kids. How do you talk to your kids and maybe your kids' teachers about whether or not you want them to keep their masks on even if the mandates have ended?
Yeah, you bet. That's a great question. And I'll just give you my medical answer. I'm not sure it would be great. We can also see what our friends at Children's are thinking, or in our pediatrics department. But here's the real thing. I think this is all about a risk calculus, and you've heard us talk about this before, right? What's the balance between your own personal risk and the safety of your own family? Here's what we know. If your family has been fully vaccinated, or they've had 1 or 2 bouts of infection with COVID-19, or they've had both COVID and vaccination, that's different than a family where they've not ever been sick and they're not vaccinated. Secondly, I would say it also depends on who's at home, right? Because the likelihood that there's going to be increased disease transmission between children within a school and there's no mask mandates is I mean, that's just clear. We know that's going to increase the risk. But we also know that it's more risky, about 2 to 3 times more risky, if you're not vaccinated or if you haven't had COVID-19, that you're going to spread the disease. And we know that even if you've had COVID-19, you're more likely to spread it than if you've been fully vaccinated. When I say fully vaccinated, I mean vaccinated and boosted. All that's a long-winded way of saying, look, it comes down to how healthy people are at home and how healthy your children are. If everyone around you is otherwise healthy, or if everyone around you has been fully vaccinated and boosted, the likelihood of having to be confronting severe hospitalization and death is incredibly low. At that point, is it safer to go and take masks? Yeah, it is safer as the disease transmission drops off so significantly, and it has really dropped off significantly. And I think what we're going to find is that when we start taking masks off in indoor public spaces, including schools and including airports, we're going to see a little bit of a disease bump. But I am, across my fingers, pretty darn hopeful that it won't be the really severe, rapid surges we've had in the past. I wish we were staggering this a little bit more instead of everybody taking them off together over a 2-week period, but I think that's obviously the direction we're headed. So my sense is this. If there are people in your household that have a higher risk of what would happen if they're obese, they have diabetes, they have cancer, they have an organ transplant, they're on drugs that suppress their immune system, I would be reluctant to have my children take masks off when they go back to school until giving it about 6 weeks or 8 weeks to see how these rule changes really are affecting the disease spread. If everyone in your home has been vaccinated or has had the infection and everybody's overall pretty darn healthy, taking your masks off as the numbers plummet like they are, probably not an unreasonable thing. But that's not, I mean, a lot of people are going to confront the idea that I have a lot of disease in my home, or we have a lot of risk in our home. And for folks that do, I would encourage you to have your kids continue to wear masks, talk to the teachers, let them know the difficulties so the teachers can be supportive of it as well, and help the other children be supportive of it. And I think if you do that, you'll keep your family safer. And again, you wait 6 or 8 weeks, that whole story may change a little bit because we can see whether or not disease transmission is really escalating as we take masks off in schools. Other questions? Okay. Now I'm going to turn to my doctor. Let's turn to our guest, Dr. Florence Aslinia. Now, I have my own irritable bowel syndrome, as you would say, Dr. Aslinia, and you taught me to go on this special diet, and I used to make fun of those diets, and thought, no, that's all in your head or whatever, and I was one of those kind of dyed-in-the-wool kind of guys. I can eat what I want, drink what I want, and I rapidly found out that's not true, and gosh darn it, the whole program worked. And so I have to tell you, I've sent a lot of patients. We have a lot of people with cystic fibrosis also have GI issues, so we send a lot of folks over to Dr. Aslinia. She does an amazing work. Talk to us a little bit about your work here and your patients, your unique clinic for the first and only multidisciplinary IBD, and tell us what IBD really is.
I'm very excited to talk about it.
I know you are, and you love to talk about it. You do a great job.
Yes, I appreciate it. So I had the privilege of joining KU in 2017, and at that point there was this unmet need to have a comprehensive, I would say, holistic approach to inflammatory bowel disease in general, which include Crohn's, ulcerative colitis, microscopic colitis, and celiac disease. So actually it was our chief medical officer's vision Dr. Stites.
Yeah, I don't know about that. I don't think that guy sees very well, actually. I'm pretty
The
sure he's
chairman
a
of
little blind.
gastroenterology, Dr. Ollier, who assigned me to the task of bringing all these people who are in charge of taking care of patients with inflammatory bowel disease under one umbrella. So I was the facilitator. So fast forward to today, we have 3 IBD doctors, 3 colorectal surgeons, 1 nutritionist, a nurse practitioner. We are searching for social workers and psychologists to join us, and a group of dedicated, hardworking nurses and medical assistants. They know inflammatory bowel disease so well. So when patients come, they get a holistic approach. And nutrition is everything. Yes, we do standard of care per book, per textbooks, but everybody follows anti-inflammatory diet, including the staff in our clinic.
So a lot of people have this thing, irritable bowel. Is that the same thing as inflammatory bowel? How is it different?
So inflammatory bowel disease in reality is a dysregulation of your immune system. So your immune system is hyperactive, is like your own soldier not following the command. And by doing that, by having a dysregulated immune system, you're going to have inflammation in the gut tissue that you can actually see under microscope. In irritable bowel syndrome, we are more or less looking at functional problems of the gastrointestinal tract. It's either moved too fast or moves too slow, and we are looking at and sort of, I would say, unknown territory of interaction of bacteria with our body. So we have FDA-approved medications like antibiotics to help with IBS. So that means the interaction that your body, your immune system has with organisms, bacteria, fungi, viruses, play a role in irritable bowel syndrome. And of course, the symptoms are different. If you don't treat your inflammatory bowel disease aggressively, you're going to have consequences. You're going to have complications of Crohn's and ulcerative colitis, which may require surgery and have its own negative consequences. IBS makes your life miserable, quite miserable, but
it does make your life. It made me pretty miserable. I'll be honest about that. And I thought, I'm not the kind of guy that's going to get it. But you sit back, you look at it, and all of a sudden you realize every time I eat, my gut hurts. I don't feel good. And then you made me go on that special diet and that low FODMAP thing and gluten-free. And I thought, oh, that's all crazy stuff. And then I felt so much better. And I was like, dang, it's not crazy, it's real. And I probably think it was kind of crazy. But I mean, I just, you look at yourself, you think, man, I need to do a better job taking care of myself. So, you've spent a lot of time to open this program, and it is an outstanding program. And again, I benefit from it. Talk to us a little about COVID and the gut. What's been going on with that?
So, do you remember the very first patient who was admitted and diagnosed with COVID-19?
I do. Actually, I helped take care of her. I was a Saturday morning. I remember I did the first pulmonary consult, and I remember I was in a spacesuit because we didn't really know how to do all the infection control back then. So we had all the stuff on back then, and we're a lot smarter now. But I do remember it.
Such a learning process. So the very first patient had nausea and vomiting for 2 days at home and got admitted to the hospital. On the second day of admission, had diarrhea, and the respiratory cultures, well, I should say PCR, and the stool test both came back positive for COVID-19. So we all know COVID-19 as a disease that is transferred through respiratory tract. And we are aware of that ACE2 receptors, angiotensin converting enzyme 2 receptor. Those receptors that can be found abundantly in the lungs also exist in the GI tract. So they can harbor the virus and cause gastrointestinal symptoms. We can also shed it through our body secretions, stool. So we used to get, it's getting better now, but we used to get a lot of phone calls from our chronic GI patients. Hey, I'm getting sick. I think I'm going to have a flare-up of irritable bowel syndrome or inflammatory bowel disease. And we quickly learned that check your patients for infection. It can be COVID-19. You will be surprised how many positive tests we've received when we send our patients to be swabbed. So it pretty much hit us fast and quick and hard.
Well, let's do a quick review. Doctor, we got Hawk in the house and then Hawk's Nest here. Hawkeye, how are our numbers here at KU today?
Yeah, the trend over the past week or so has been going down.
It has been going down.
So we're glad about that. 39 active infections with 7 in the ICU, 3 of those on the ventilator, still 77 in that recovery period, but a total of 116 patients. So overall, Steve, like we've been talking about, our trends are consistent with what we're seeing around the nation, but we also know that these hospitalizations, they have been coming down a lot slower than the cases, but we know that's what happens. Hospitalizations lag those cases.
Yeah, I think Dr. Williamson calls it watching for the paint to dry. See our numbers dropping.
Yeah.
Guys, do we have the heat map? All right, so this is our current heat map, and if you remember back when the heat map was just solidly purple, look how much better it is today. It's just gotten so much lighter, which is great news. And I think it goes back to the question we had a little while ago, Hawkeye, from one of the reporters, is that, gosh, what happens with the mask mandates all ending in schools? What do you tell kids who you still want to have, who should still be maybe wearing masks? And I kept saying, the numbers are dropping. At some point, we're going to have to take masks off, but you got to do your own personal risk assessment at home, what's going on in your home environment, what's going on around your family. And if you have people who are still at risk, and especially if those folks are not vaccinated, trouble could be coming to us as we open up all the mask mandates in schools, and looks like we're going to be taking away mask mandates on the airlines and in the airports here in the middle of March.
Yeah, and I think there are many aspects to these decisions. Again, the medical, the public health, I think you would still wear masks. We know that there are other psychological, psychiatric, economic reasons for doing these things. I don't think it's such a bad idea if we can keep the kids in school as long as possible this year. That way, they can complete the school year. It may not be a bad idea if some school districts or some schools do continue mask mandates. But again, we know the importance of school. We know the importance of getting those kids together, keeping them together for that social interaction and things of that nature. But we also know that there are multiple factors that go into making these decisions. So.
Yeah, and a lot of them, I think, is a personal risk calculus. Because they say we're not going to mandate it for everybody doesn't mean that you shouldn't do it yourself, especially if you think there's a higher level of risk. And at some level, that's what we all have to think about. And we know that it's important. And Dr. Aslinia, you know a lot about wastewater testing as well and what happens. Tell us a little bit about that. How can we use wastewater testing to help us detect the community spread of COVID?
So this is actually a fascinating field.
Actually, it is pretty fascinating. We talk a lot about it on this program, and I never thought I was going to be talking so much about stool and poop and water, but we do a lot of it.
Well, yes, I'm the poop doctor.
You are the poop doctor.
So, healthcare officials would like to know what happens. It's like weather prediction. They want to know what will happen a week from now, 2 weeks from now. So one way of figuring this out is looking at the hospitalization for COVID-19 or, let's say, the positive test from swab clinics. But in September 2020, the Center for Disease Control and the U.S. Department of Health and Human Services collaborated with other federal agencies and decided to come up with genius idea of creating this tool by the name National Wastewater Surveillance System. So in this organization, they just check the wastewater and check for the concentration of the virus particles. So if the concentration is going up, that means you're going to have a surge. If you look at their website, which is publicly available, it's amazing. It matches.
It totally matches it.
Oh, yes.
Yeah, and it gives about 2 weeks worth of warning. The wastewater testing goes up. 2 weeks later, it's really predictable. We're going to have another surge. And it's good stuff.
And you catch those who are asymptomatically carrying the virus, those who are mildly ill, but they decide to stay home, not get tested, but they still contribute to the wastewater, though. I can guarantee that.
And the funny thing is we saw those wastewater numbers go up, and they reached a higher point than they've ever reached, even before all the testing went up. And we know that a lot of people didn't get tested, to your point. A lot of them are mildly or asymptomatic. So what percentage of COVID patients do you think suffer GI symptoms?
Well, if you want my biased idea.
Well, I know it's going to be biased, but you go right ahead.
So in our field, there is a close association with between the brain and the gut. So this gut-brain axis is very well known, right?
Yeah, you got
so
me on that
even without getting infected, when you feel like, okay, this is March 2020, people are dying, I don't know what's going on, there's no treatment, there's no vaccine, nobody knows what's going on, this is going to create so much anxiety that, your gut feels like it's falling apart. But we quickly learned through research, through evidence-based medicine, how to deal with it, have a vaccine, wear your mask, do social distancing. And then our patients started to get sick when they came out of complete isolation. Some people developed long haul, post-COVID long haul syndrome, which is, again, anxiety-provoking, but with hand-holding and with conservative, supportive measures, they will get better. Again, nausea, vomiting, diarrhea, abdominal pain, lack of appetite are prominent symptoms of COVID-19, reported in 20 to 50% of patients with COVID-19, depends on the study you're looking at. So we should take those symptoms very seriously.
Well, isn't it feels, one of the problems with the gut is it's only got so many ways to express its distress. Distress. Oh, my goodness. Express its distress. That was the problem. To me, zess in there. But, like nausea, vomiting, abdominal pain, diarrhea. And gas. That's the other thing, right? That your gut, when it's unhappy, it shows you those stories.
Absolutely.
And then our job is to figure out, God, why is my gut unhappy? Because the reality is when your gut's unhappy, it's your whole body that becomes unhappy. We think about the gut as just something that's going to absorb our food, but it's a really, really big organ. It's one of the biggest organs in the body, and it contains all these bacteria and fungi that have to be in good balance. We need the right ones in there, otherwise things go awry.
Absolutely. And now we know about dysbiosis. That means the balance of the bacteria, or let's say microorganisms in general, in your GI tract can be affected after such big infection.
So does the vaccine affect our gut? COVID vaccine, I should say.
Actually, very good question. I was doing my own homework before the interview to see if vaccine can adversely affect our GI tract, give us GI symptoms. So I can't find any robust evidence behind it. So if anything, the vaccine can help us stay safe and not get the infection, which may result in acute and possibly subacute to chronic GI symptoms that can basically affect
And
your
you
life.
talked about hand holding, and I know what you said to me is you should be less stressed. And I said, make COVID go away. I think is what I said. Yeah. But you talk about how do people reduce that stress in their lives? Because I think our guts feel the stress.
Right. I think this is something that I wished we were taught at school if something like this happened, how to become resilient, how to reach out to your loved ones. And, I work in a clinic that accommodates chronic illnesses. So these patients become family. When they come to you and say, doctor, I'm not vaccinated. So you ask, my dear, why? Why? The answer that you hear is, I'm scared. So when there is such close relationship, your doctor, your nurse, your healthcare provider could be your family, could do the hand holding and say, okay, let's talk about it. You're scared. I understand. I was scared too the day I got my vaccine in December 2020. I can't believe time flies.
Oh, it does fly.
You talk. You try to convince your patients by providing the evidence-based medicine quality of care.
So what's the impact of COVID on patients who are already dealing with other GI tract diseases like IBD, gluten sensitivity, celiac disease, things like that?
Worsening of symptoms. So for, especially patients who are already in remission, they contact you and say, well, you know what, I was doing well, and now I'm having these symptoms. So the first question that we ask is that, have you been sick with upper respiratory tract infection? Have you been in contact with patients who were diagnosed with COVID-19? And if they don't have current symptoms, I probably won't check them, won't test them. just share the idea that yes, it can be a flare-up, it can be any infection, but we are in the middle of a pandemic. So let's see if you're currently suffering from active infection or you're recovering from an infection that you didn't even realize that you had it. It was subclinical, you're recovering nicely. And we have a protocol, we run our tests to make sure that there is nothing else going on, like worsening of Crohn's, worsening of ulcerative colitis, contamination with gluten in a patient who has a celiac disease. So it's a process for sure.
Mm-hmm. It is a process. This whole thing is a process. And Hawkeye, you see a lot of people with COVID-19, and I'm going to guess a certain number of those folks have had some GI problems as well.
Yeah, we learned fairly early on, just as we heard our guest talking about the GI symptoms there. And again, I think a lot of it is related to those receptors on our body that the virus attaches to. They can be found all throughout our body. Some organs more than others. Obviously, the lung is very high, the GI tract as well. So we know that can impact your symptoms, and we know that those symptoms do occur maybe as earlier symptoms as compared to maybe even some of the other more classic symptoms that we've thought of. But we do know those symptoms can occur. But luckily, I don't think there have been any long-term chronic effects specifically for the gut with the disease. We know people have long haul and things like that. Not sure really if there's a lot of long haul symptoms with the gut itself, but again, we know the infection can affect all of our organs. The gut is probably the second or third behind the lungs, I would say.
So, Dr. Aslinia, how do I know if I have COVID-19 in my gut, or if it's my celiac disease, or if it's another disease? Is there anything about COVID-19 that distinguishes it to let me know that, gosh, I should be testing?
Unfortunately, there is none unless your swab comes back positive. You can do your, investigator's work and talk to the patient. Hey, did you have loss of taste and smell a couple of days ago? Or maybe your son was sick and did you test him for COVID-19? But otherwise, sometimes you're just confused and you continue to rule out what you can rule out. Like we have objective measures to see if Crohn's is getting worse, if ulcerative colitis is getting worse, if there is gluten contamination. These are science-based, objective, we have tests. But if this is the consequences of having had COVID-19 and now you're suffering from the sequelae of such insult to your systems, it's sometimes very difficult to tease that out.
Yeah, it can be tough. Well, we're glad you're out there taking care of these folks. I know you guys have got you got busy, you've grown, and things are getting better and better for your practitioner program in IBD, and we're really glad that you're here to do that. Jess, let's see what questions we have from viewers.
We have a lot, and yes, this is
I bet we do. The gut questions are always good ones, and I know we got the right person here to answer them.
Yes, I just want to start with a couple of comments because Pamela says, I'm so glad that Dr. Aslinia is on. Back in November of 2020, she had COVID, had major GI issues, ended up in the hospital. She still has GI issues, and people were kind of like, I've never heard of that with COVID. So some doubters. So she feels really grateful that you're on to say that this is actually a real thing. Heather, let me go with Mary. Mary has a question. Had her gallbladder removed 5 years ago, still having issues with loud tummy noises, frequent trips to the bathroom. One day she can have a salad and everything's fine. The next day, not so much. She doesn't think this might technically be irritable bowel, but it sure mimics it. Do you have any advice for somebody who does not have a gallbladder, and how can you make that connection?
Well, I bet you're going to talk about gut healing here, aren't you?
I would love to.
Yeah, go ahead.
So I had a little bit of technical difficulty, and
there's somebody had a gallbladder removed and has had it continued 2 years ago, still has GI issues, and one day they can eat a salad, next day they can't, and without GI bugs, or without GI distress. So talk to us a little bit about what does it mean to have your gallbladder removed? What are the complications from that, and what can people do to help solve that?
Absolutely. So post-cholecystectomy diarrhea is a very common problem. We sometimes discuss that even prior to cholecystectomy, that we're going to take your gallbladder out, but you're going to have diarrhea. Sometimes it improves in a matter of a year, and sometimes our patients continue to have it and live with it. So what happens is that your gallbladder works as a reservoir to hold the bile and release it when you eat. But when you don't have the gallbladder, you constantly have this flow of bile into your gastrointestinal tract. So the diarrhea that is the result of cholecystectomy is called bile-induced diarrhea, which is a sort of osmotic diarrhea. So what we do is we give our patients medications such as cholestyramine to bind to the bile and prevent such diarrhea. It's not optimal because it also binds to other oral medications and interrupts the absorption of other medications, like if you're on thyroid medication or blood pressure medications. Sometimes your body just learns to absorb bile and diarrhea gets better. But in your particular case, I think there is more than one issue going on, because I'm not quite sure if you have an underlying irritable bowel syndrome, which is common in women. If you have some food intolerance, which anybody can have, it may not be the salad, it could be the dressing on top of the salad that doesn't agree with your body. So it's complicated.
It is complicated. So when I saw Dr. Aslinia, I had this I still have my gallbladder. I had some of these complaints, and she said, okay, here are things you got to get rid of. It included, I had to eliminate garlic and onions. And I'd already kind of known garlic bothered me a little bit. And I tell you, I did this low FODMAP diet, and there's a whole guide out there. You can find apps for it. Changed my lives. I felt so darn better. And then you start trying to reintroduce some foods to figure out what's wrong. And you know, garlic is still is an enemy to me. It's very difficult to eat out when you can't tolerate garlic very well, and so you end up trying to get you just say, "Chefs, can you fix this for me?" And pretty soon, all you get is just the green beans, the mashed potatoes, and the food doesn't have anything on it. So it does change, but you feel a lot better when you can identify what those offending agents are. But it's really a process of trial and elimination.
Absolutely. It's a whole different lifestyle.
Yeah, it actually is a lifestyle, and you have to follow that lifestyle, but it does make you feel a lot better. Jess, other questions?
Well, Mary also just had a comment, Dr. Hawkinson. She's in Salina, and she just wanted me to send her regards to you and thank you for taking such good care of her husband when he was in the hospital for 75 days. This was like 5 years ago, but she remembers you well and wanted to send you some well wishes.
That was even before COVID. People liked you before COVID. What happened with that?
Actually did work before COVID. Thank you. That's much appreciated.
Yeah, right.
I hope everybody is well there.
Shannon has a question. Her daughter vomits every time she's given probiotics. Any reason why?
I am so sorry. I have
okay, so there's a daughter
here.
who is vomits every time she gets probiotics, and so trying to understand why would that be? I hadn't heard of that's an interesting one.
Yes.
Yeah.
So vomiting after taking probiotics.
Yeah.
That's interesting. I'm not sure if I have a science-based answer toward it, but remember, pills are not just the elements or molecules or agents that you aimed for. They have ingredients. So there is a possibility that the stomach is intolerant to the ingredients. In addition, a lot of pills are not well taken by stomach if it's empty. So she may take it with full stomach and do well.
So you had a thought there too, Hawkeye, and
yeah, it was exactly what she talked about with the pills. I wonder, I think you can get some probiotics in yogurt too. I wonder what the formulation is that she's getting the probiotics, but I would certainly echo what we just heard about the pills themselves.
Yeah, you do wonder about what happens with yogurt because it's not really a pill yet. You can get some of those really active yogurt cultures, and that can do almost as well as different pills can. So that could be a really good thing as well. Okay, Jess?
Dr. Stites, I'm just going to sneak in a quick COVID question because we've got some more GI ones.
But it's still out there.
The
map does look a lot better.
It does. So we're getting fewer and fewer of those questions, so that's good. But Joe wants to know, can you comment on the BA2 variant? Just any updates and your thoughts?
Yeah, you bet. Hawkeye, I think the answer to the BA2 variant is that we want to know the answers, but it's still so darn early. There was an article last week that talked about how BA2 may be more serious than people are thinking. It could lead to more deaths and more hospitalizations. Couple of comments. We have had a lot of deaths, and we've had a lot of deaths in January and February from COVID-19. Yeah. And one of the things we said about the Omicron variant was that, it's not as serious. But we've had a lot of deaths, and we've had a lot of patients. And so as a proportion of it, it's not as many deaths, but we've just had so many darn patients. The problem with the struggles in the United States is we don't know, because we don't do enough genomic analysis. And I suspect I'm going to be talking about this in the weeks to come, how we need to beef up public health so we can pivot more rapidly. But we don't. And we don't have the public health infrastructure to answer the questions about what happens when new variants come about. So here's what I know. I know the heat map is dropping across the country. Hospitalizations are dropping across the country. Deaths are dropping across the country, even though there are reports of the rise of the BA2 variant. So I don't know where the truth lands in all of that, because we don't have the public health infrastructure to really know how many of our patients in the hospital today already have BA2 and what the real percentage of it is out there. Here's my overall feeling. Things are getting better, so that's going to include whatever component of BA2 is out there. Hawk, what do you think?
Yeah, I would agree with that. I think, just as you mentioned, there is early data saying one thing. We know there's early benchtop data looking at how it evades the virus, how it evades some of those monoclonal antibodies, how those monoclonal antibodies may not bind well or at all. We also have early data, like you said. This week, I was looking at medRxiv, which is a preprint server. So these articles that are written and before they go through peer review, preprint, that was from South Africa, some of that group that we got early data about the original Omicron, which looked and showed that there really wasn't much different severity of BA2 compared to BA1 or the original Omicron. So I think, just as you said, Steve, it is early. We are going to get all of this data. I think overall what we have seen, and when we talk about severity, we have to understand right now we are using the standard as Delta, because Delta looked to seem maybe have higher risk of hospitalization, maybe have a little bit higher risk of severe disease. But when you look back, even with Omicron and the original Wuhan isolate, we know that there is that spectrum of severe disease, and we know, just as you said, we have seen people die from Omicron. So we know Omicron does cause severe disease and death. And I think as we get further into this, we are also going to have the caveats and the confounders of people having vaccine-induced immunity, which again is always safest, but also vaccine plus infection, and then those people who've just had infection, maybe once or multiple times. And so that type of immunity is also going to confound how we are using and looking at that data about severity. But as far as the answer to that question goes, Steve, I would totally agree with you. We just don't know. We know that in some places BA2 has displaced and become the dominant variant. We haven't really seen that yet here that we know of. So I think we just have to kind of wait for the data to come in, and it may be a few weeks. Hopefully, if we are very lucky, we will continue to see just an overall decrease in the cases.
Yeah, and here's the other thing I'm going to say: Jack, be nimble. Jack, be quick. Jack, jump over the COVID stick. And that could have been a Jack or Jackie. I don't know who it is. But the point is the same one, though. We have to learn to be much more nimble around COVID-19. And the way to be more nimble is to have the right information. The way you have more information is you gather all the data you can, which means you have to have a better health infrastructure. The one plea I would have out there to all the governing bodies and everyone is, let's make an investment in the public health infrastructure so we know wastewater testing early, we know where we are on things like the BA2 variant, and we can track what caseload's doing. So if we have to say to folks, let's go do this, it's really data informed. Because right now, we have to wait about 6 weeks after things begin to escalate out there to really react. And in that 6 weeks, we're allowing a lot of stuff to happen. Whereas if we have better public health infrastructure, we could do this in a much more rapid fashion. And then when things really start to drop and we know infections are then we can go ahead and do things like relax mask mandates or change our medical approaches, et cetera. But right now, we're so far behind because our public infrastructure is so, public health infrastructure is just not very strong in this country. And that, if I was going to do one thing from this pandemic, I would say let's invest in that so we can really track the information and we can answer these questions so much better, so much earlier. Unfortunately, I'm just not hearing that conversation, Hawkeye.
Yeah, no,
we're fighting about ivermectin,
totally
but
agree.
we're not going to do the thing around public health infrastructure, which will really help us save lives.
Yeah, and now is the time to do it. Obviously, we've been going through this for 2 years, Steve. I think you hit it right on the head too. We've early on too. We noticed those disparities in public health and infrastructure and all that. So I think it's important. The forest fire is down a little bit right now. It is much more able to be managed. Hopefully it will continue to go down and decrease. So right now is a time to jump on these things. Public health infrastructure, increase the ability to do sequencing and get that data out in a timely manner. Continue to endorse and get those vaccinations into arms while the cases are down, and you can have time to mount that protection. So a lot of these things about medicine and public health, we should be jumping on right now. This is the time to do it.
Jess?
All right, back to the gut. Vicky and Diane and Angela have questions about what is a good pre and probiotic. Should we all be on a probiotic, no matter what your age? And is cottage cheese a good probiotic?
Yes. So the answer for the second question is yes.
We should all be on probiotics. Is that right?
Well, I'm going to have an answer that will disappoint a lot of people because
Well, you're going to tell the truth. Go ahead.
I'm going to tell you because
best to know.
we practice evidence-based medicine. When the evidence is out there, it's hard to ignore it or speak otherwise. So meta-analysis, we are looking at large studies, gathering the data from many validated studies say that there is modest effect to no effect in terms of using probiotics for managing your GI symptoms. So the take-home message is that if it's working for you, well, take it. It's either working or it's sugar pill. It's not going to hurt you unless you're undergoing chemotherapy. If your immune system is really, really, really suppressed, because you can have infection associated with probiotic intake. Otherwise, if it makes you feel better, take it. If you don't see a difference, don't waste your money, because science doesn't support it.
Is there one yogurt that's better than another?
I don't have scientific evidence to answer this question.
But some do taste better.
Yeah, that is
There you go.
point well taken.
Yes.
Okay, Joellen wants to know if you could talk about the pros and cons of using blenders and juicers when you're making drinks in the morning. Are you getting rid of some really good necessary fiber? And just discuss soluble and insoluble fiber.
Oh man, the things do we reduce our fruits, etc., into stuff that's not useful when we create these super drinks?
So theoretically, yes, but again, when we take super drinks, I mean, the stomach has only so much space, and you're trying to, let's say, build muscles. You need certain amount of proteins and vitamins in. So there is no way, except for condensing it. So that would be the price of losing some fibers, which is, I would say low price in terms of delivering vitamins or proteins. So it's always an exchange. So you want to build muscles, you just came back from the gym, and you need this highly concentrated drink that has protein, help you to recover. Okay, take it. And then later on, take your 5 portions of fruits and vegetables.
So if you're saying that if I take these kind of muscle building formulas, I could have a biceps like Hawkeye.
I think so.
I don't know if it's true. Do you use those muscle building drinks?
No,
Yes.
I don't.
No.
No,
So it's just
again,
natural.
I think this goes back to some of these original questions. I think it's just important to have a healthy, balanced diet,
Right,
and
that's
that is, for lack of a better term, it's staying on the outsides of the grocery store, right? Please jump in, but it's the fresh fruits and vegetables. It's the protein, whether it's lean protein like fish, or it's the other protein like chicken and meat. It is some dairy if you can tolerate it, but it's staying with those fresh fruits and vegetables and an overall healthy diet, I think.
So what you're really saying to me, Dr. Aslinia, is that those Cherry Orchard sour cherry gummies that I like to snack on are probably not the best food group. Is that right?
Probably.
Yeah, I noticed it's a
Sour
Food
Patch
Group.
Kids are great. Yeah.
They are really good.
Tastes good.
Okay, Jess, now I'm disappointed again in life. Go ahead. No garlic
Well,
or sour cherry.
you gave me some of those for Christmas,
They're really good, aren't they?
and I ate the whole bag, and I felt so sick. I deserved it.
I did the same thing last week. I got started and I was really hungry and I was trying to stay awake. It's late afternoon meeting. I got to like, oh, my sour cherry. Let's eat the sour cherries. I did not stop. It's like
I know you can't,
right.
but
You
they're
can't.
so good. But I paid for it.
And homemade buttercream frosting.
There you go.
That's healthy too, right?
Yes.
Yeah.
Butter,
Sure.
some dairy in there, cream.
Amber wants to know, do IBD patients experience more extreme COVID symptoms? And what do we do to get somebody who's had gut issues from COVID? How do we get them back to good?
Okay.
Excellent question.
That is a good question.
Yes. So we have very few medications that are approved for treatment of COVID-19. And 2 out of 3 are biologic agents that we use for treatment of inflammatory bowel disease. One is a JAK inhibitor, the other one is anti-interleukin 6. And we use similar medications in the field of inflammatory bowel disease. So what we rapidly
And what are those
learned-
drugs? Tell us what the JAK inhibitor and the IL-6 inhibitor, which drugs are those?
It's a tongue twister. You have to help me.
Go right ahead.
I can't.
I can't either, see it right off the top of my head. But I think it's a monoclonal antibiotic therapy that is
Yes.
probably it is some of the same stuff. And,
They know you're
and,
gonna help us?
Yeah, sortrovimab.
Citrovimab?
Yeah, is
Yeah,
that
the
one?
monoclonal antibody?
Yeah.
And the JAK inhibitor. So what we learned is that our patients do not have higher mortality. They do not have more than expected GI symptoms that you see in general population. As a matter of fact, they slightly do better than general population while they are on biologic agent, because the biologic agents teach their immune system to behave appropriately and don't create cytokine release, which may result in multi-organ failure and potentially death.
So, Jess, you had a couple of quick questions I think you wanted to get through there.
I do, and then we're going to have our doctor back on because this is a very popular topic.
I could have told you. Dermatology, these GI things, we're just going to get, this is the best stuff, right?
Yeah,
So.
we can all relate some way or another. So Janet just is asking real quick, did she understand this correctly, that immunocompromised people should not take probiotics?
If they are receiving active chemotherapy or, let's say, bone marrow transplantation, stem cell transplantation, we advise against taking probiotics.
And the reason is that those things can leak into your bloodstream and make you really sick, Hawkeye. And
Yeah.
we know that's really true. I know the lung transplant population,
Yeah.
same kind of story.
Yeah, that's exactly right. You know, it doesn't happen frequently, but there is that risk there. Anytime you are using live bacteria or, for instance, live virus vaccines, but live bacteria as you would be taking from those probiotics, there is that risk, exactly like you said. It can seep into the bloodstream and cause a bloodstream infection. So I think the risk factors that she went over were exactly right. And it is a risk. So just be careful. And again, if you are getting immunosuppressive medication or chemotherapy or bone marrow transplant, please talk with your medical team about if you are planning to take the pills, the probiotic pills, because we know that can be a risk.
Okay, 2 last questions, Dr. Stites. Kip wants to know, what is the doctor's thoughts about taking Metamucil every day?
As the source for fibers, the answer would be yes, it's a wonderful source. Of course, we prefer you to have your cooking cup and have that filled with fruits and vegetables 5 times a day, but in Western's life, it's really, really hard to achieve that goal. So if you want to put 2 tablespoons of Metamucil in the morning in your coffee or mix it with your yogurt, it's a good idea. Just a word of caution, Metamucil is not water soluble. In patients with irritable bowel syndrome, it can cause a lot of gas and bloating. So we recommend Benefiber. They don't pay me to advertise for them, but it's water soluble. So you will do better. There will be less gas and bloating if you get any sort of water soluble fibers, including Benefiber.
So along that same line, Joyce wants to know, do unrefrigerated probiotics work, or is it better to have the kind that you refrigerate?
A very smart question. I love that. So we have certain probiotics that are refrigerated. So they are better controlled. So they're more predictable when you culture them. Let's say you buy it, you culture them in your lab, and the manufacturer says these are the number of colonies that you're going to get in one pill. The chance of you receiving what they promised you to receive is higher if you buy those. A good example is VSL3, which we use a lot in patients with J-pouch after colon resection in ulcerative colitis patients. But otherwise, if you're just, trying to improve your constipation or, have less acne, I don't feel there's a huge difference if you buy those, fancy refrigerated VSL3 or get something off the shelf that is not refrigerated.
We got to get her back, Jess, because we need to talk to her. She told me I couldn't be taking all these non-steroidal things like Motrin or Aleve or ibuprofen or all that and Naproxen. So, there's so much we need to talk about with you. So we got to have you back soon. We are going to get some final thoughts from everybody. And Dr. Aslinia, I want to start with you.
Yes.
What are the final thoughts you'd like to leave our audience with today?
I told you 22 years ago, this day, I had a surgical procedure that resulted in a beautiful baby girl. That C-section resulted in a beautiful, healthy baby girl. She's a medical student now. And this morning when I was driving, I thought, there is an end. Even if there is happiness, there is pregnancy, or, disaster like pandemic, there is an end. So when you're in the middle of that event, try to get the most out of it. Try to be smart. Try to use your judgment. And the same thing with pandemic. If you feel wearing mask is going to protect you, do it. Listen to your doctor, get your vaccine, and be wise, be kind, be resilient. This pandemic was supposed to make us resilient. I hope we achieve that goal at the end of it.
Yeah, that was really well said. Yeah. Thank you. You got to get back soon. Hawk?
Yeah, I think there is some light at the end of this tunnel right now that we are going through, and I think as we stated before, now is the time to be proactive and jump on those things such as vaccination, such as trying to help restore or improve the infrastructure of our local and state public health as much as we are able to. And I think that we're looking for good times ahead in the near future. So, but again, just as Dr. Stites talked about, understand that individual risk and weigh those risks and benefits of anything you're going to be doing and keeping yourself and your family safe.
Jess, before I toss it back to you, here's my thought. What does the future hold? What does our future hold? And are we a part of that future or are we not? Meaning that, do we construct and build the future, or do we simply exist and see what happens around us? And I think as the pandemic goes down and a little and takes a respite for all of us, let's hope we can keep it that way. Last March we had like 5 patients. That felt great. I felt so much safer. You go out and do the things you wanted to do, and I'm really hopeful we're headed to that same level again. But then here we come back this winter, and we were at 224 patients. That is one heck of a swing for hospitals. That's our new normal. But are we victims, or are we participants? How do we control our future, and how do we control our destiny? Do we simply watch and see what others do and say, that's what I'm going to want to do? Or if I want to ignore the science and just do whatever I want? Or do I want to try and actually help guide us into a place where we can all be safer from this type of a pandemic? I hope we choose to be those who help build the future so that we can all be safer and keep that safety and that shelter for as long as we can. And that means you're going to have to make good choices. It's no different when you tell your kids when they go out to college, make good choices. Do the right thing. Try to take care of people and everyone around us. And so when things come, when mandates and masking stops across the country and in airports, etc., make sure that you make good choices. If you're sick, if you don't feel well, if you're vulnerable, keep your mask on. If you're otherwise healthy and there's nothing bothering you, you think everything is good at home, you take your mask off, you think you can do it safely, Godspeed. But at the end of the day, if we want to keep the real heart of this pandemic at bay, keep our gut safe, keep our heart safe, keep our lungs safe, keep our family safe, keep our kids safe, keep our brains safe, make good choices. Jess?
All right, Dr. Stites, thanks so much. And thanks so much for being with us today. You can catch our shows anytime by logging on to Facebook, YouTube, and on Twitter. Okay, coming up tomorrow, it's really a case of supply versus demand. With more people now showing long-haul symptoms following their initial battle with COVID-19, the health system is making changes to its long-haul clinic. Now, instead of just a few people helping, the network is now expanding what these changes mean for you and when they will take effect. That's tomorrow at 8. Alexis.
I'm Alexis Del Cid on the next All Things Heart.
It's not always easy when you know that your son is going to pass away and you're going to live on. You know, it's not an easy thing to take in. One time I said, you know, give him the heart, you know. You know, I'm an old man. He's a young man. Give him the heart.
A father and son, both in heart failure, only one could survive. The common symptoms that turned into full-blown heart failure. Join us Thursdays at 10 a.m. for All Things Heart, live on Facebook and on YouTube. And be sure to bring your questions.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.